Adam, thank you so much for the time today.
Thank you for having me.
Now, to start, can you explain the differences between recovery focused care and harm reduction approaches?
So, recovery focused care is what we traditionally think of addiction medicine. So, this is the kind of care where you try to wean someone off of their substances and eventually shepherd them into recovery. And the idea is that they should ideally be abstinent, or if they are taking drugs, it should be in the form of methadone or Suboxone, which is technically a long acting opioid, but in such a small amount that you can't really consider it drug use. Now, in opposition, you have harm reduction, which is a movement that really gained traction in the early 2000s and then exploded in 2010s. And ostensibly, harm reduction is about reducing the risks associated with substance use. However, it's also a social justice movement that posits that there is nothing inherently wrong with drug use and that doing drugs is not inherently harmful or bad, but rather it's the stigma around drugs and the criminalization of use that is bad. And so for harm reductionists, they often view abstinence-oriented care as being unjust and stigmatizing, and even believe that drug use is a human right.
Now, in your article, you mentioned that even doctors and addiction experts are divided on this issue. Why is the medical community so fragmented when it comes to this?
Well, there's a really interesting history here. So, I mean, for decades, the recovery-oriented side was dominant. And then starting in the early 2000s, the harm reduction side gained more traction. It had a lot of international investment from, let's say, the Soros Foundation, and it was viewed as the sexy and innovative way to deal with drugs. Now, in the 2010s, you had the rise of fentanyl. So fentanyl is this hyper-powerful opioid, which is 50 times stronger than heroin, and that significantly increased the number of deaths happening in North America. At the same time, fentanyl made traditional addiction treatments less effective. So I mentioned earlier methadone and Suboxone. So these are long-acting opioids that you give to an addict in just the right amount to meet their cravings, so they don't have physical withdrawal, but not so much to induce euphoria. So if you're addicted to fentanyl, which is 50 times stronger than heroin, your opioid tolerance is going to be very high. And what that means is that it takes a longer time to get someone onto the appropriate dose of methadone to manage their withdrawals without getting them high. And so for someone who's addicted to fentanyl, that process can take about 2 weeks, which means, which may be nothing for us, but for someone who is in active addiction and who is homeless, that's a lifetime. So when you have this combination of surging deaths and then methadone being less effective, the harm reduction movement came in and said, look, we need to stop the dying as soon as possible. And they got a lot of buy-in. They were seen as innovative. And so we had the rise of supervised consumption sites and we had the rise of safer supply. Safer supply refers to the practice of giving addicts free addictive drugs, predominantly hydromorphone, which is essentially government heroin, to try to dissuade people from using illicit substances. The problem, though, is that safer supply didn't really work, and supervised consumption sites have, the science behind it is quite mixed and often leads to a lot of community crime. And so there was some skepticism, and some addiction doctors said, are we really doing the right thing here? Are the interventions working as intended? But in the late 2010s and the early 2020s, you weren't really allowed to say that. For many physicians who criticized radical harm reduction, they faced activist harassment and they were at risk of losing their jobs and having their grants jeopardized. And we have to keep in mind that harm reduction is seen as a very progressive approach, and so it is associated with progressive politics. And we all know that in the late 2010s and early 2020s, we had, I hate to say this, but peak woke, right, where that was very dominant. And so these people, these addiction physicians, they couldn't speak up. But then as the public became exasperated with the level of addiction that they were seeing on their streets, with the level of disorder that they were seeing, suddenly recovery-oriented care came back into fashion. And people said, you know what, we're not going to treat drug use as a human right. We're not going to destigmatize drugs. We're going to hold people accountable. And now, because the power dynamics have shifted, the harm reduction side has been somewhat discredited, especially after BC's failed decriminalization experiments. The recovery-oriented side is more powerful. You have a fairly raucous debate between these two sides, with each side now striving for some level of dominance, and some people saying, well, wait, how do we work together collaboratively versus adversarially?
Now, last week, Premier Scott Moe announced that Saskatchewan will table forced drug treatment laws this fall. Here's what he had to say.
Compassion and recovery care are for those that are struggling with addictions need by introducing legislation that will require individuals who may be a threat to themselves or others to enter into addictions program, ensuring that they get the help that they need while keeping our communities safe and secure. But what this is another step in really the evidence-based recovery-oriented system of care that we are putting in place and focusing on in this province. First, by building out the capacity of the recovery beds and treatment that we have, and second, by building access points, whether that be through urgent care center, complex urgent care centers that we have, complex needs facilities that we have in the province that also are an access point, and this would be an additional access point. For a very, I would say, small number of individuals, if any at all. It would be for those individuals that very much are likely facing arrest, as they would be in a situation where they are in danger of harming themselves or harming someone in the public around them.
Now, do you think that other provinces should create forced drug treatment laws?
I'm agnostic on the issue because although I understand the importance of getting severely addicted people off the streets, the question is, do we have the capacity to absorb them? And so what addiction physicians in my circles often bring up is, how do you have the wide-scale use of involuntary treatment if you don't even have enough capacity to provide voluntary treatment? At the same time, I think that this is something which could be useful for a very select number of cases. The kind of people who, are in and out of jail so severely addicted that they're a danger to themselves and others. And there's a precedent for institutionalizing them. We institutionalize people who are going through a mental health crisis. If we conceptualize addiction as a mental health problem, we can use the same framework. And sure, that might use up some capacity that could be allocated to voluntary treatments, but in the hierarchy of who needs treatments, this, obviously would take priority, especially if we're looking at restoring order to our streets. Now, the problem is that the evidence base behind involuntary care is quite thin and quite mixed. So we're not sure if it really works. And we know that even voluntary treatment has a very high failure rate. Oftentimes people have to go to rehab multiple times. So if you're giving someone involuntary treatment, so they don't even want to get better, and we already know that voluntary treatment has a high failure rate, then we know that for these individuals, they're going to have to be involuntarily treated again and again and again. But it's better than doing nothing, and at least it quarantines them from the rest of society when they are in treatment, and giving them some chance of getting clean and of being healthy and thriving and not being a harm to themselves is better than just leaving them on the streets to slowly die.
Well, Adam, thank you so much for breaking that down for us. We appreciate it.
Thanks for having me.